Hi everyone. This is a really exciting in-person event. I'm really happy to welcome you to our Emerging Scholar presentation. As you know, we participate in a Emerging Scholar exchange program with UCSF, UPenn, and Michigan. I got to do it this year. It was really fun, and I'm sure we all know people that have done that. So we're very excited to have you here today. We also got to meet at my UPenn visit, so this is very serendipitous.
Old friends.
It's what,
we're old friends.
Now we're real old friends, so it's great. But Dr. Chén Kenyon is a pediatric hospitalist at CHOP, and he's an assistant professor of pediatrics at the University of Pennsylvania. He's also a faculty member at Policy Lab and the Center for Pediatric Clinical Effectiveness at CHOP. His research focuses on integrating care systems and reducing outcomes disparities for children with asthma. His recent work focuses on developing novel interventions to enhance asthma control or medication use in highest risk children by leveraging mobile health technology and incentives oriented to the child. I think there's a lot of things that will be of interest to many different groups within IHPI in this, so we're really happy to have you here, and I'll let you go ahead and get started.
Thank you so much, Sarah. Really appreciate it. All right. All right. Thank you so much for inviting me, and I'm really excited to be part of the exchange program with the Emerging Scholars program. Really excited to be here at University of Michigan. I so much respect the quality of the work that comes out of here and the quantity, and have a lot of people from my past who I get to meet with today and tomorrow, and I'm really excited to have those conversations. I already just had a really great sort of conversation with Jeff Colgren to sort of prompt my some of the thoughts that I'll probably be expressing a little bit during this talk. This talk is called Leveraging Technology and Behavioral Science to Promote Medication Adherence and Health Equity in Children with High-Risk Asthma. I have sort of a range of projects that I work on, and I consider myself a health services researcher with a specific interest in environmental and social conditions that influence sort of host factors and drive child health. So asthma is sort of a perfect condition to study, and I have a number of different projects in different domains with respect to asthma and drivers of both asthma onset and morbidity. Some of this focuses more on the higher policy level factors, and then this talk is going to be focusing a little bit more on sort of the health behaviors and sort of inside of the box of healthcare. Just for a disclosure, I serve on a committee that reviews efficacy of medications for a national pharmacy benefit manager, but it's not relevant to this particular talk. In terms of my objectives for today, what I would like you to leave here with is the ability to highlight the major racial disparities in pediatric asthma prevalence and outcomes and a framework to understand them. Describe overall rates of adherence to controller medications and average differences by racial group in the United States. To assess the strengths and limitations of technology and incentive-oriented intervention strategies to improve asthma medication adherence. And then discuss the challenges and opportunities of these intervention strategies with respect to improving equity in asthma outcomes. So I'm going to start with a little bit of background, since this is not necessarily a pediatric audience, although we have some pediatricians represented. Childhood asthma has been called the most disparate of pediatric chronic conditions, and I'll go into some of the data behind why. This is the older data from 2016, looking back to 2015 in terms of the prevalence of asthma in the M.S.H.P survey. This is collected by the CDC and goes back about 30 years, and you can see sort of increasing asthma prevalence over time. This appears to, in more recent CDC data, actually have leveled out a little bit. So this downtrend that occurs, I don't know if I have a cursor here. Yep. The downtrend that occurs here actually appears to be real, at least in the average rates and in the white population. But there are these pretty profound differences when you compare Black populations, non-Hispanic Black populations to non-Hispanic white populations. And the prevalence of asthma in urban populations in places like Detroit and Philadelphia is quite a bit higher. And if you look at just our 3 CHOP intercity practices, you take the total denominator of patients who go to those practices, about 22% of those kids have an active asthma diagnosis, meaning they have an encounter and a medication prescribed in the last year, asthma medication prescribed. So quite a higher prevalence compared to some of the national averages of around like 8. And actually the 2020 data suggests that asthma prevalence may be as low as 5% in children right now, nationally. So this is I'm a pediatric hospitalist, and one of the outcomes I try to prevent is kids coming in to see me. And so I focus a little bit on preventing ED use and hospitalization, but also missed school days and other important disparities or outcomes that we want to avoid. This graph compares the Black and white populations over time from 2000 to 2010 in terms of hospitalization rate. The graph on the left, on your left, is the population-based averages, and because asthma is more prevalent in Black populations, you'll see that gap sort of narrows when you look at when you account for that. And one of the good sort of news, one promising statistic in terms of asthma disparities or disparities in general, is that over the 2000s there was actually a decrease in the disparity in hospitalization rate for pediatric asthma, again when you account for the different prevalence by racial groups. But if you look at, again, these inner city minority populations, the rate of asthma hospitalization is not the national average of like 2%, it's about 7% of children with asthma getting admitted every year. And then potentially the most concerning disparity to highlight is one with respect to death, sort of the most important outcome that I think health services researchers look at, and that we should be concerned about more broadly. Fortunately, the number of children who die from asthma every year is only 204, but it's 204, and it's a ambulatory sensitive condition where we have effective treatments for it. That is, of course, lower than the adult average, where asthma tends to have higher morbidity. But if you look at the differences in asthma death rate per million, when you compare the white population to the Black population and non-Hispanic Black in the United States, it's an order of magnitude. It's a 10-fold difference in mortality from asthma, which is a statistic. Again, this is from 2020. This difference is recent, and I would argue completely preventable given the right sort of health system and the right set of social systems to prevent these outcomes. So in thinking about this is a complex problem. I alluded to this earlier. I sort of come at this from a number of different angles. This is from about 15 years ago, a framework for asthma disparities that highlights some of the broader legal, economic, and social cultural parameters that sort of underlie all of the differences that we see. They broke it down into healthcare system and individual and community systems, and then their interface. We think, I work within Policy Lab, we think a lot about sort of policies and sort of social factors that can potentially influence outcomes and disparities. There certainly are things within like insurance status, reimbursement levels, like what formularies actually cover. Medicaid formularies tend not to cover SMART therapy, which is a new NIH endorsed therapy that I'll talk a little bit about towards the end, but getting multiple combination inhalers prescribed or covered in a month is something that you have to really struggle with Medicaid, whereas private insurance companies, they make it a lot easier. I think I mentioned I sit on a pharmacy and therapeutics committee for one of the large private insurers in the United States, and within several months of the new NIH guidelines coming out, we had changed our recommendation to the formularies in terms of how many combined medicines we could prescribe, should be allowed each month, so that families should be able to get 3 combined inhalers each month. And with Medicaid, we can't get past 1. And so that's certainly like a policy level change that has impact when you get into the delivery of care. And then this gets focused on a lot, and we focus on a lot on this as well, the social and environmental context. This is a sort of an older graphic, poverty, indoor and outdoor allergens, pollution, environmental stress. I would definitely put racism in this at this point, and knowing all we know now, I think there was certainly a more of a the social norm was not to necessarily include that in published papers at that point. But what I'm going to be focusing on today is a little bit more in sort of in the box. And so thinking about the operation of the healthcare system, provider and clinician factors, how they interact with potential modifiable factors around beliefs, health literacy, illness management, with respect to, in their intersection, access to treatment. So getting into that sort of within the box, thinking about medication adherence as a potential mediator. And so this next section, I'm going to talk a little bit about why differential medication adherence may mediate some of these differences in outcomes. And it starts, there was a bit of an interactive portion to the presentation here. I'm going to ask, I have a couple of quotes that I'm interested in getting, and seeing if anyone in the group can come up with the people who are the owners of them. So this is sort of like the face validity of this. There hasn't been a lot of studies that have sort of actually broken down, like with various multi-level data sets, like differential medication adherence, differential social environments, differential environmental contributors in terms of what contributes most to the asthma disparities. Something I've been interested in the past, although it feels very descriptive. But this is just establishing the face validity with respect, first of all, to the efficacy of inhaled corticosteroids and the medications that we use to treat asthma. So this is a quote that I ran across when I was a third-year medical student, I think, and it's really shaped a lot of my thinking around disparities. When interventions are highly efficacious, then differences in the use of the interventions will dominate patterns of health outcomes. When interventions are of low efficacy, then differences in underlying risk, including those that are social in origin, will dominate patterns of outcome. Anyone want to make a guess as to who is responsible for this quote? A pediatrician, Paul Wise. He published this in a paper in Health Affairs back in 2004. And really, again, it was a pretty formative article and something that I've kind of gone back to from time to time, thinking about like the efficacy. If we're going to solve health equity issues, we have to have efficacious interventions. And this is just one slide that demonstrates what we know well about inhaled corticosteroids for the treatment of asthma. This is a study, the Trexa study that was published in Lancet by Fernando Martinez back in 2011, and it represents just one of the most well done, but very, a lot of literature that has looked at different approaches to asthma management. And this was mild persistent asthma. So people should children be taking a daily controller medication, or can they take a daily controller medication just when they have symptoms, or is it help to take both of them? And this is a survival curve. It goes out to 365 days. Sorry, I cut off the axis here. And this is the proportion of children who have an exacerbation. And what's notable about this is that the daily and the combined, clearly there's a lower proportion of children who have an exacerbation going out to 365 days when you compare that to like rescue use or just using albuterol alone. So placebo is that they didn't have inhaled corticosteroid medicine in the placebo inhaler. So this is sort of establishes that the hazard reduction here, there's about a 50% risk reduction in the rate of exacerbations when taking daily ICS, which has become the foundation of like the asthma guidelines, both in the United States and then internationally, at least for children. So the second part of this is the face validity, or sorry, the sort of lack of adherence. So we have established pretty well established the efficacy for this particular medication. This quote's a little bit easier, and it has some CHOP connections. So I don't know. Does anyone know who who owns this quote? So he was a former Surgeon General of the United States, and he was the Surgeon in Chief at CHOP for a long time. It's C. Everett Koop. So I think this came out in his sort of like in his Surgeon General days when he was. I've heard a lot of stories about him being now at CHOP for 10 years, and so he has a legend that lives on internally. But he also had a huge like policy impact, and this was one of his quotes in his Surgeon General days. And this has notoriously been a problem for inhaled corticosteroids, even more so than chronic medication use for chronic conditions of adulthood, like antihypertensives. You see that the rates of inhaler use are even lower than some of those sort of pill-based regimens. And this was a review that was done by Bruce Bender in Colorado that shows over time, we're not necessarily seeing like improvements. That the rates that people generally cite are around 50%. And even if you get in sort of the more recent ones, we're actually, as we get better at measurement, we're actually realizing that perhaps people take a substantial amount less than 50% of their prescribed medications for inhaler use. And then if you break it down and stratify it, yeah, absolutely.
Question about that, how does it vary by age across childhood and adolescence? Given that this is a combination probably of parent and child adherence.
Yeah, so it sort of, it differs, you know, that generally there is a dip in adolescence, as you might expect. So as so one of my psychology mentors has looks at like shared medication responsibility or shared responsibility. And so when that is higher, when the parents tend to control the medication use, the medication tends to be higher. And then as there's a transition to the child, as you would see with like toothbrushing and like a number of other things, like there starts to be a dip off. And then in adolescence is sort of when you see like perhaps like the lowest adherence. But it's all like all these statistics that are always given about adherence are averages, and adherence is one of those things where like the average means nothing, because usually it's like there's patients that are compulsive and take their medication consistently, and those that take their medications very rarely, and then there's some that take them intermittently. So there definitely is some age-related effects, and if you look at sort of stratify by race and look at sort of urban minority populations, the estimates are much lower, both on, if you look at medication refill data and the electronic monitoring data, which I'll show you a little bit of what we've been doing with respect to that. In that, you know, on average, children are probably taking about 20% of the prescribed medicines, again, in some of the highest risk groups. So this sort of sets the stage a little bit, you know, hopefully, convince you to some degree that medication is at least a plausible mediator. Differential medication adherence is a plausible mediator for the differential health outcomes that we see for childhood asthma. Now, there's been an explosion of new technologies that have sort of promised to solve this problem, and a lot of them are app-based solutions. Some of them are electronic monitoring-based. I highlighted a number here. These are sort of several of the more common. Adherium, which used to be called Smart Inhaler. Cohero, which is a small company based out of New York. And then Propeller, which is a company that I've worked with, actually all of these now, in doing some medication adherence monitoring. And so all of them have a platform that they have developed to help children and families monitor use. A lot of their materials and a lot of their data is really on like early adopters and sort of focused on, you know, like you don't see a lot of, like if you go to some of these websites, you won't see a lot of minority populations represented in their advertising for sure. you know, the initial, I was sort of coming out of my fellowship and was working, I just published a study looking at medication fills, like using a state Medicaid claims data set, showing that, like, you know, if you fill your controller medication and actually your rescue medicine, within 3 days of being discharged from the hospital, you're at lower rate of readmission to the hospital. And so it's kind of gotten into a little bit of thinking about, you know, interventions with respect to adherence and this as a potential mediator of outcome disparities. And then there was a study that was published out of New Zealand, and there's several of Adherium or Smart Inhaler was based out of New Zealand, which I think was a lot of the early studies came out of there, showing that just in this randomized trial, you put this big blocky sensor, which was like the old version of what these sensors looked like before they became sleek and got into, you know, user-centered design labs, and you had it, you randomized people to that sensor going off an alarm every time someone was supposed to take their medication, versus not, that they saw this really dramatic improvement in adherence going from 84%, going from like the control group mean of 30% to 84%. And you can see that the intervention group is represented in blue on this group. So most of the blue bars are in this 70, 80, 90% adherence range, whereas like that is not the case for the control group. One of the things that may have been going on in this is that you had to take the medicine in order to shut off the alarm. And so it's unclear if people were actually taking the medicines, but they did show that there was a higher asthma or better asthma control in the group that was receiving the alarms. So I think there was initially sort of this, as I'm sure you've all experienced, this hype around technology potentially solving these problems. And a local managed Medicaid MMCO came to our group and was like, you know, we saw the studies, we'd like to do the same study. We'd like to do the same study in a high-risk population in the United States, we'd like to, you know, address this problem here using the same type of an intervention. And they had a protocol for, like, you know, a large randomized trial that we were very concerned about the potential of like adapting what their protocol was to our patient population, and really sort of like said like, well, why don't we just start with just a very small pilot study where it's not controlled, and we just try to see get a sense of sort of feasibility and acceptability in our kind of higher risk cohort. And we partnered it with a community health worker program that we have that has been now at CHOP for about 25 years and is pretty strong data suggesting both efficacy and effectiveness in the real world. And so I still have not lived down the reputation of this study with the community health workers, because they ended up being both the tech problem solvers for families, and they ended up accusing a lot of families of not taking their medicines, and it sort of changed the nature of the relationship with them. But we learned a ton in this study, and we learned several things, like that at the time the sensors needed to be charged. You had to like plug them in several times a week, and families were really, first of all, they didn't have outlets that they could put that they could charge them in, and they were concerned about the energy bills that were associated with it. And we did a lot of qualitative work trying to understand the other factors that were sort of associated with it. And we learned a tremendous amount for that initial qualitative or mixed method study that had a pretty strong qualitative component. And it got us to this point of like at least knowing the limitations. Like we started to buy power strips for families, and if we're going to include them, and we talked to them about like how much energy it actually uses, like how much is this actually going to affect your energy costs, so that people had a better sense of that. And we enrolled families we ended up enrolling high-risk families in a text message-oriented intervention to try to improve adherence following hospitalization. This was oriented towards acceptability and feasibility. And we followed them for 30 days after discharge. This is our second pilot study. The first one was just kind of a wash. The second, so in this study, day since discharge is on the x-axis, and average adherence in the population is on the y-axis. Again, we were just looking at acceptability and feasibility, but we had this limited look at actual adherence. And as you can see, the confidence intervals are huge, but there was no sign of effect of like the intervention at all. And what I like to tell people, my colleagues in hospital medicine, is that like, so we were able to recruit 50% of people. They were willing to put an actual sensor. 50% of families were actually willing to be part of the study. So this does not represent all of the families. And in that group of people who were like willing to be involved in research, the max that we got up to in adherence in the month following hospitalization, where, so the salience of the child's asthma should be very high on people's mind, was 60%. And by the end of the month, it was below 40%. Like families were only able to provide about 30% of 30 to 40% of the medicines that are prescribed. So it's at least demonstrating that locally that the medication adherence, is consistent with what the prior data has been published, and is pretty inconsistent. So this led us to think a little bit more, and we are at, trained at, and so joking with Jeff Colgren a little bit, training at Penn and having the influence of like Kevin Volpe and the sort of like the behavioral economics crew. We sort of trained in the heyday of behavioral economics, which I think has maybe started to wane a little bit. And we started thinking about like, well, we sort of have a cue and a routine that we're prompting with this, but like, is there some sort of reward that we might be able to offer and target to the children that may help to promote adherence in use of the medicines? And this is a graphic that's poached from The Power of Habit, which is by the journalist Charles Duhigg. Really, actually, pretty nice. If you haven't read it, it's a nice summary of sort of habit formation, some of the habit formation literature. He actually has good like end notes, and so you can get into some of the science that informed his writing. And it's a little bit simplistic, but I think is a good place to start. And brought me to like the pediatric literature. Most of the behavioral economics work that Kevin and David Ash have done historically has been in adults. And so there was this one promising intervention by one of Kevin's collaborators, George Lowenstein, that looked at a kind of policy relevant question where in the state of Utah, there was 8,000 children in 40 elementary schools that got randomized to either a 3 or 5 week token economy where children could earn $25 for every, or 25 cents for every fruit or vegetable that they selected at the lunch line. And this was a pretty like rigorously measured study. So they actually put monitors at the trash cans to make sure that the children didn't throw away their vegetables and fruits. And they were able to show in this, this is sort of the main graphic. So at baseline, before they so everyone got incentives, but one group got 3 weeks of it and one group got 5 weeks of it. And this is like testing the hypothesis as like does it take 60 times to form a habit or whatever? And is that potentially something that is a strategy that's feasible in childhood or more feasible in childhood? So at baseline, children selected about 40% of children selected one fruit or vegetable at their lunch line. You offer these gain frame token economy, and everyone goes up. You basically double the number of children who are selecting fruits and vegetables, and then you take it away, so at 1 month and 3 months. And what they showed is that what you expect is that there's going to be a decrease after you remove the incentives. But in the group that got 5 weeks, there was actually a lower decrease in the incentives, and this was statistically significant both at 1 month and 2 months. So kind of interesting, promising data suggesting that maybe like duration is important and may lead to at least some marginal benefit in terms of habit formation. And then, I sort of looked to my other colleagues. So this is a study by Charlene Wong, who used to be at Penn and is now at Duke, in JAMA Peds, where they looked at children with type 1 diabetes and they incentivized them. They did loss framed incentives for glucose monitoring and there's sort of an intervention period and a follow-up period represented on this graph. The intervention was about for 3 months. For whatever reason, 3 months is a popular time to do length of interventions, and the proportion of children who are adherent to glucose monitoring. And they saw a pretty substantially different rate, like I think it's like a 20 to 30% difference in terms of daily glucose monitoring in this group. But then again, when you took away the incentive, there's a sort of gradual regression to the control group. So when we were setting out to do this, we did a review of the literature. There isn't much out there. And we just actually published a narrative review last year looking at promoting childhood healthy behaviors using financial incentives. And what we found, sort of again, this wasn't a systematic review. We weren't able to do meta-analysis, but there's really like an equal number of studies out there that show that gain framing and loss framing sort of work in terms of delivery of incentives in children. And there's a lot of concerns about using loss-framed incentives in children, and the sort of perceived concern for fairness and establishing trust with children. So that was at least one thing that we saw as a pattern in the literature. Timing of delivery is important, so you want to try to reinforce a behavior sooner rather than later. And then, as I'd mentioned from the George Lowenstein article, the longer you can provide incentives, the better. And then there is some data both in children and adults that small rewards can actually outperform larger rewards. There's this concept of reference dependence, which I think this sort of alludes to a problem of the developmental problem in pediatrics. My 4-year-old vaguely understands the concept of money, but is more going for getting the quarter than what he can do with the quarter. And then as you get older, I think there's a variability there in terms of what money means to children in terms of what they can actually do with that reward. And we tried to incorporate that into our intervention by trying to have conversations with children about what they would like to purchase, not just a thing, but sometimes an experience like going to the movies with their family. And then this is a point that often comes up, is the effect of incentives on intrinsic motivation. And one thing that I like to say on this is that there's a lot of controversy, and this is a pushback I got when submitting my K award, which was sort of focused on this, about the concerns for the effect on intrinsic motivation. I don't think that this is necessarily 100% this debate is dead, but when children don't have any intrinsic motivation, when people don't have any intrinsic motivation to do something, you're not going to decrease it by introducing an incentive, right? It's not there to start with. So I would argue that there's really little intrinsic motivation among children to actually take a daily medicine that doesn't make them feel better, unless they're just trying to be a good child or a good patient, which I don't think there's many children who are trying to be good patients. So I think this was sort of the summary that we did and informed our design for the next pilot study. So this one we used the Way to Health platform at Penn and sort of integrated a sensor, a medication sensor, onto this platform. And so we sort of set up this queue of a daily reminder to the parent's smartphone that prompted inhaler use, and then the sensor that we put on the child's inhaler would recognize that. This sort of alludes to some of the technology challenges that come up. So you need pretty good Bluetooth technology to then feed the sensor back to the smartphone, and families have to keep it on. So there's a sort of logistical issues there. We ran into a lot of Android, in this iteration, a lot of cheap Android phones that had poor Bluetooth and didn't really give us the best data feed, at least in terms of real-time data feed. And then your smartphone then has to upload either by a cellular network or by Wi-Fi to a back-end platform for us to actually record the medication use. And so we found that this is this was done a couple years ago, and so a lot of our families didn't have Wi-Fi, and so they're using cellular data to upload. And we found that we weren't able to provide the sort of immediate feedback that we would like to try to form a habit. And we had to do it sort of on a, weekly is sort of what we ended up landing on. And so we would provide feedback for the family that, your child took 10 out of 14 puffs and earned $5 this week. This goes towards their video game that they had selected. And then we would give them some encouraging messaging. Your child's goal is to take at least 3 out of every 4 controller puffs, 75%. Try this week, you got this. We would give them some encouraging messaging around that. And then, so as I mentioned, we incentivize them up to $1 a day for full adherence with their controller medication. In this study, we were able to recruit our target cohort. We're primarily focusing on non-Hispanic Black population, children who had mostly public insurance, and the family income levels were 65% had less than $30,000 a year, and then families with pretty poorly controlled asthma. So a score of less than 19 is in the asthma control test is considered to be uncontrolled or poorly controlled. And then these children had an average of 3 hospitalizations in the last year. So children who are having frequent utilization of the healthcare system. And what we found, and again, this was a feasibility and acceptability oriented study. 94% of the families found the daily reminders and weekly feedback helpful. And most of those wanted to continue receiving the reminders and feedback. I don't think I mentioned this. It's a 1-month intervention and then a 1-month observation. So we did the intervention, so non-randomized, pre-post design, just to kind of test the concept. 90% of families would have liked to continue receiving reminders and feedback in month 2. And then incentives, we were interested in this. So only 75% of families that we were in the intervention liked the idea of receiving the incentives during the intervention month. Some families felt, and qualitative data has really helped us to understand this, how the interventions are received, that the children should take their medicine no matter, they shouldn't need an incentive to take their medicine, was some of the families' sort of feedback on this. And then some felt like it was like bribing their children to take their medicine. But it's funny, if you ask the same question the next month, 94% liked the idea of receiving the incentives once it was taken away. So they sort of felt utility in it, is what I perceive of this shift that we got from some of our acceptability data. And then we had this very promising pre-post sort of effect. So this is just a spaghetti plot showing the adherence in the month 1, where we had, again, monitoring, reminders, and incentives compared to monitoring alone. And average adherence was 80% in our first month, and then dropped by 47% in the second month. And this was the pilot data that we then used to submit the work that I'll now talk about in terms of the randomized trial. What we took home from this, though, was that we were able to engage this high-risk minority cohort in a technology-enhanced financial incentive intervention. The strategy was both feasible and acceptable to caregivers. They liked the financial incentives and they wanted them for longer, but they didn't necessarily want more messaging. Which we kind of took away. And then there was a signal for better adherence, but it's a pre-post study. There's many concerns with it in terms of Hawthorne effect and bundling the interventions together. And so that led us to the current study, which I have a bit of an unconventional K award that has a randomized trial as its first aim. It can be done. Everyone was like, don't do it. But it was what I wanted to do, and it was a resubmission, and I felt like there was an opportunity. I had some good data. So what we set up was a 3-arm RCT that had a 3-month intervention period and a 3-month observation period. And in this study, we would give families, we'd have a run-in period of a month where families would have the opportunity to get their technology set up, communicate sync data back to us through the Way to Health platform, and also respond to a text message that we sent through the platform. So we knew we'd sort of establish our data loops. And then once they got to that point, they got randomized to one of these 3 arms. In the arm 3, our active control arm, they got just electronic monitoring and the platform in which they could view their child's medication use. In arm 2, for 3 months, they got reminders and feedback, weekly feedback, same intervention as the pilot study I just showed. And then in arm 1, we added financial incentives to that. And then after 3 months, the 2 active conditions reverted to the active control and just received electronic monitoring to assess for enduring effect. We enrolled children 5 to 12, 125 families, 2 systemic steroid courses in the last year. We initially were targeting children with 2 or more hospitalizations, but then COVID hit and no one got hospitalized for childhood asthma. And so we had to lower our criteria and change the demographic a little bit of the population that we ended up recruiting, because we ended up going further out into our primary care network. And then had to be on a controller medication. We used the same incentive approach of 25 cents per puff or up to $1 a day. And we had reward conversations with each family on enrollment to try to tailor the reward to the child, something that was interesting to them. And then inhaler use was monitored using the propeller sensor. So this is our consort diagram, which may be a little bit small, but we enrolled our target group. 106 were randomized. 42, it was a 2-to-1 to 2 randomization scheme because we were powered to detect a difference of the full arm, the full intervention arm to the active control arm, and we were just looking for whether there was sort of a middle-ish effect in the hybrid group. So the randomization was balanced. We lost several people to follow-up, and about 38 were included in the main analysis from our Arm 1 full intervention, 21 in the Arm 2, and 40 in Arm 3. And again, it was a relatively small randomized trial, but it was pretty balanced in terms of some of the characteristics that we cared about. So race, there was about 80% of the participants were identified as non-Hispanic Black. About 50% had incomes lower than 50% of the poverty level, and that was pretty well split. There was a little bit of difference in the marital status or married or living with partner, comparing the full intervention group to the active control. 50% in the active control were married, and caregivers were married or living with their partner, compared to 26% in our intervention arm, which wasn't statistically significant, but it's a pretty small sample size. And then this was our prior utilization. So it wasn't, again, the COVID pandemic affected our utilization a lot for asthma, so the kids didn't have as many ED visits and hospitalizations, but on average had uncontrolled asthma, and then their run-in adherence was about 50% in each of the groups. So the punchline, this is the sort of main figure, which I'm presenting this at PAS, but so on the x-axis is time in months. We have a run-in period, and then 6 months of follow-up, 3 months of the active intervention, and then 3 months of observation. In the red, with the red dot, red solid line, is the full intervention arm, and then the hybrid arm is in green, and then the active control is in blue, and this is the unadjusted results, but as you can see, there's generally a higher on average adherence in our full intervention arm, about 15% higher adherence to controller medications, although that effect did sort of decrease over the course of the study. And we found exactly what Charlene Wong found in her study, that when you removed and what has been shown in a lot of adult studies, that when you remove the incentive, the effect of on adherence essentially went away. There was no statistically significant differences in adherence in the observation phase between the 3 arms. And then one more. I'm going to get to my secondary outcomes, which the adherence we were powered for an adherence outcome in this study, but the prelude to our secondary outcomes is that. Our secondary outcomes disappeared during COVID, and this was, I worked with some allergists during the COVID intervention or COVID era to demonstrate this, that our average rates of encounters for asthma-related ED visits, hospitalizations, and intensive care use when the COVID pandemic hit went below 3 standard deviations of the mean for the prior several years, and really this was over we just looked at this over 9 months following the onset of the COVID pandemic, but it really took about 18 months. It was about an 18-month period that asthma utilization was dramatically lower because of social distancing and likely the effect of viral sources in triggering asthma exacerbations. So we weren't powered to show a difference with in utilization, and we we're with COVID, we're not likely to find one. It looked like, and if you just looked at dichotomized the outcome of like whether a child had a hospitalization or not, pretty similar numbers by arm. We did see in terms of ED use, and this is the 12 months following, so you know, there was only effect for 3 months, and so how much of an effect of 3 months of adherence would you expect? But there was only about 20% of children, less than 20% of children in our full intervention arm had an ED visit compared to over 30% in both of the other arms. And then if you look at oral steroid courses, this was a secondary outcome that we had to add when we changed our eligibility criteria during COVID. We also saw that there was a lower proportion of participants, a grossly lower level, 30% of participants who had a oral steroid course compared to, if you looked at our active control arm, as around 50%. These were not statistically significant, but there may be a sign of a little bit of an effect. So I'm going to wrap up here and then invite questions and discussion, but I just wanted to highlight the main findings, talk a little bit about the neuroscience correlates. I'm not a neuroscientist, but I've kind of focused on it in terms of learning, one of the learning aims of my K, and then potential future directions. So what we showed in this study was that daily text messaging, weekly performance feedback, and gain-framed incentives resulted in a 15% higher adherence during the intervention interval. There was no evidence of sustained effect or habit formation during the observation interval. And what I sort of characterize this as is sort of two problems. There's problem one, which has been well documented in financial incentive space and reward space in general, is sort of this problem of habituation to incentives. And then this sort of drop off, or like there's habituation and there's like lack of habit formation with financial incentives. And I hardly had to move the slope of these arrows to sort of do the same thing for Charlene's study. It's like, it's almost exactly the same. And you take, as many of you may be consumers of the behavioral economics and incentives literature in adults, very similar patterns in the adult world. So I think one of the questions is, like, are there key logistics of the intervention strategy, like timing, like we're not delivering the reward, soon enough to sort of form a habit? Or is the duration of incentive, like, should we just do this for 6 months? I would argue, like, with that decay curve in arm one, like probably 6 months is not going to be the solution to the problem. And so where I'm trying to like push this sort of discussion is more towards like understanding the neuroscience of habituation and habit. And if you'll allow me to indulge in a little bit of a popular neuroscience definition. Do I have any neuroscientists in the room here? Oh, good. If people with more training in this space feel free to chime in. But if you haven't read the book Behave by Robert Sapolsky, he's a primatologist and a neuroscientist at Stanford, who has written this just beautiful book on behavior and the science of behavior that starts like the milliseconds, like what's going on from a neuroanatomy, neurophysiology perspective, the milliseconds before a behavior, which parts of the brain are communicating, what's happening, and then he goes back a day, a week, and looks at hormonal changes and different sort of factors that maybe, and then he goes back a decade or to stressful times that people have had in their lives that may have reset their barometer, and then he goes back to adolescence and childhood and early exposures and details the science. He actually then goes back like evolutionarily. He's thinking on a large scale. The connections get a little bit like less tight as you get further and further out, but it's a beautifully written book, so I recommend it. And this is a graphic from it that he's sort of drawing a cartoon about like dopamine, how reward works in people's brain and how dopamine is associated with reward. I mean, so it's a similar like cue, routine, reward, and it's in that habit loop. And once a reward or once a sort of a habit loop has been sort of conditioned or a reward loop has been conditioned, this figure just shows that more dopamine, this is anticipation, so more dopamine is released in anticipation of a reward than actually for the reward itself once that reward has been conditioned. And the problem with habituation, and this was me like on my dry erase, I probably could have done it on the board here, is that with habituation you see a decrease in the peak of this, and this is just well-documented science, like that many experiments with primates pressing levers to get raisins or bananas have shown that the dopamine release over time goes down in anticipation or as you habituate to the reward. And what his solution, one of his solutions that he brings into this is this idea of uncertainty, which I think has really been popularized by behavioral economics, but I think is maybe a little bit misunderstood in that in these experiments they showed that when you conditioned a response with these monkeys, and then you made it the sort of secret percentage or proportion of times in terms of uncertain response is 50%. So you can drive up the dopamine response with response to like a work, like how much, like when the monkeys actually sort of experience the rise in their dopamine levels, but it peaks when you're at 50%. So doing a lottery is not going to get you there in terms of establishing a reward. So these types of things are sort of the science that underlies the idea of like boosters for incentives during, we've had conversations with our Medicaid managed care companies, and they're like, if you can show us that you improve outcomes with incentives, like we'll pay patients. It's $365 a year if versus that's less than one ED visit. And so we're happy to do this. And so I think that there actually is a responsiveness to like there are circumstances where just paying families and children to take their medications is potentially plausible. And that there's been some pushback from like using public dollars to do that in adults, but that has not necessarily been at least tried in children. But the other problem, the bigger problem, is problem 2, which is the lack of habit formation. And so this is sort of a condition. This is a habituation. You've established this reward cycle, but now you've taken away the reward, so there's no bump in dopamine that happens at that point. And there's some data from like mouse models that the association with a particular place in the cage when a light comes on may lead to some sort of conditioning of them wanting to stay in that area. Once you take away the reward, but there's really no literature in like primates and in humans and other primates about the sort of reward sticking once you remove the incentive. Jeff Colgren and I were just talking about this for a while in terms of like where to go with this, and I think where we need to go is towards this idea of habit formation. I think there's certain circumstances where we can overcome habituation to incentives and where it's probably very reasonable to pay children to take their medication, but don't expect it to lead to a habit unless you start working a little bit more with this idea of internalization of external rewards, tailoring and evaluation, like what do the children actually care about? And can you actually orient the idea, like somehow associate the behavior of like increased use of their controller medication with something that they actually care about, like being able to climb the stairs with their friends at school or being able to play basketball with their siblings and not feeling limited by that. And I think that's where I think this work needs to go, and there probably needs to be more interdisciplinary collaboration between health services researchers and people sort of looking at this on the sort of neuroscience level to get there. And so I think I covered the replacement of short-term and because everything that we have done is really oriented towards short-term rewards as opposed to long-term rewards. I've also, where I'm going with an R01 application that's coming up is a sort of, can we actually get smarter? And can we create like a reward-like intrinsic effect? And so I'd mentioned this sort of SMART, which is single maintenance and reliever therapy, where children children and adults 5 and older who have are not well controlled on a daily maintenance controller medication can step up to a medicine that includes a short-acting, immediate onset long-acting beta agonist. And so you're actually getting the immediate feel of response to a medicine, which potentially could sort of fit into this mold of like feeling a response or feeling a reward from medication use. So again, this is smart therapy. I mentioned the sort of what it is, but one of the things that it really does that I like from a health equity perspective is it like takes the many controller and rescue medicines that families have stored in their house and simplifies it to one inhaler that they use on a daily basis and when they have symptoms. And there's been studies this has been studied very robustly in Europe and South Africa. There's a lot of efficacy and effectiveness data out of those places, at least with kids 12 and older. And we're interested in sort of looking at this more from implementation and effectiveness in younger kids as well. Just simplifying complex medications and potentially both that simplification and that sort of immediate effect of the medicine leading to improvements of adherence, which have been shown in non-adherent patients in randomized trials. So, last slide here, back to like the health equity theme. So, this is one sort of theme that one area of research that we pursued, really again looking at kind of individual behaviors. Can we use technology, invest in sort of tailored technologies that really target our highest risk populations? Some of the things we've run into is that there's a sort of lack of anchor habits, and we get this from qualitative work. When families tell us that it's a single mom who's trying to get 4 kids out the door in the morning, and they're like, there's quotes that we have like, we're lucky if we get like breakfast in the children and maybe brushing their teeth. So like getting medication to 1 or 2 or 4 of them is next to impossible. I mentioned the technology disruptions as being a challenge that I think is better than it was. I think COVID has had an effect of like, Wi-Fi, low-cost Wi-Fi is a little more accessible, although I think we need to continue to monitor that problem. But that is another challenge in doing this work. Engagement, recruitment, retention is always an issue. Transportability of efficacy data in pharmaceutical trials is an issue that I've started to get a little bit more interested in that, like, if you don't have representativeness in the efficacy trials, that then you can't assume the same effect that you might see in one population versus another, especially if there may be genetic differences in terms of ancestry with response to medication. And there's some suggestion in the asthma literature that there may be that effect going on. And then another problem that I think comes out in this work is like it's putting the onus of disparities on the family and the individual, as opposed to the more systemic effects and systemic interventions that we need to do to promote health equity. So what I do think where there are opportunities is health behaviors contribute a lot to outcome disparities, and a lot of those are maybe not necessarily the most modifiable. A lot of those are very understandable given the circumstances and stressors that families are exposed to. But I think that we can't ignore that as we pursue health equity research. What I argue to people is that we're not putting these technologies back in the box. So we're figuring out they're improving. These sensor technologies are improving, and the early adopters are who tend to be more affluent and white are experiencing the benefit from them. And so if we don't figure out how to adapt them to our minority and low socioeconomic populations, then the disparities are going to get worse. And there's real outcomes, morbidity, mortality, as I mentioned from the beginning, to prevent here. There's a lot of opportunity for robust effectiveness data. And a range of funders are interested in sort of supporting this work. I've been funded through the NIH as well as payers and certain foundations for this work. The Robert Wood Johnson Foundation obviously is looking for ways to promote equity in outcomes. And so there's a lot of opportunity here. So opening up to discussion and questions, what I wanted to just highlight on my acknowledgement slide is that I have the wisdom of some maize and blue in my team. So Michelle is a research assistant who is just graduated actually from Michigan last year and has been wonderful. And William and Ray, my whole data team right now is Michigan trained. And then I actually don't know about everyone, but I know those people. We talk about Michigan during Michigan football season. They're like talking about it on our calls. These are my funders and collaborators, and happy to take any questions that you all may have. I'm a pediatrician, so I had to put a picture of my kids on the slide. Any questions?
Thank you for sharing your work. This is really great. I really like your text messaging intervention because it's so accessible for a wide variety of populations and different uses of smartphone. But in terms of talking about building internal motivation and some of the interventional strategies around that, I know gamification has become really popular in other populations, and there's some pilot stuff around pediatric asthma. But did you incorporate any of that in a little bit with your behavioral economics?
Yeah, I mean, when Way to Health, the platform that we were using, was like starting to get into more like gamification abilities, and there's been a number of my sort of contemporaries at CHOP who do kind of M.H.P. type research have worked on gamification too. A lot of them have worked, with sort of developers to sort of, and I think I think the strategy is just really, it's a tough one because I think you're competing against industry and that are just much more, they know what works much better than and they're because there's a lot of fad that occurs in childhood in terms of what games are popular. It's really hard to keep up with the times, and I feel like academia is such it's slow-moving process that I've seen people develop games based on Minecraft and other things, but by the time that game comes out, the next generation is onto their new set of games. Although I think Minecraft is still somewhat popular in a small age group. So I think that's developing now, and it's probably a good point that I can come back to Way to Health and talk a little bit about what gamification sort of menus they have. But it just has to be something that is we chose money because it was the easiest thing, and it's fungible, and we felt like if we could try to have a tailored discussion around incentives, then we might get to more towards people's intrinsic interest. But I think that certainly is another avenue to pursue.
Maybe we can talk more about it in the future. You have a lot of great points there.
Yeah, great.
Question, if you go back to your main outcome slide from the clinical trial, the graph over 6 months, it actually looked like by month 6, your intervention group was doing worse, and if that had been sustained, if you'd followed them out to 8 or 9 months, that might have been a statistically significant difference. And is there any reason to think that the intervention group could be worse off? Not, and you were comparing to Charlene Wong's where they came together, but it didn't show this kind of further dip out at month 6.
Yeah, so we've talked about this a little bit. It's a good point. I think what I'd say is that so people are concerned about what this has been called in the behavioral economics literature is a negative contrast effect. Once you remove the incentive, then there may actually be a worsening. You're actually, again, if there was any internal motivation to do this behavior, you may have just removed it completely. What I'd say is that, it's hard to, because I'm glad we included the arm 2 because I feel like they actually dipped lower than there was no incentive included in them. And then we're looking into this a little bit, what's happening with arm 3 over time. And there may be there's more dropout in arm 3, which is our active control arm. And so one of our hypotheses is that we're actually just retaining the kids that tend to adhere and the families that tend to adhere. But we're doing some further sort of statistical analysis to sort of see whether if we kind of use if we impute the values from earlier on from that group, like, do we see like a similar trajectory? Because you're right, like what we don't want is to have a deleterious effect on a behavior that we're trying to promote.
The question I had is from your dopamine graphs and what you showed about like 50% reward rate
Yeah.
might actually do better. Did you think about doing, instead of 25 cents for every puff, 50 cents for a random half of the puffs?
Well, right. So I think if I was going to do it now, that's what I would do. I would start with, I would start with a fixed rate reward. So you're getting a reward every time you do something. And then to deal with the habituation problem, I would, and I talked to the people who are the most helpful practically on this. There's this group of like certified behavioral analysts. So we have them in our medical behavioral unit in the hospital. They're sort of like they're the most limited commodity in the hospital, because we have tons of children who are in the hospital with troubling behaviors, and whether it's troubles with medication adherence or all these other things that bring them in. And this group is like really focused on, they like eat up like and they develop incentive schemes for like individual children. And so that's what they suggested. They suggested, from the beginning, and this is even before I was planning, and I just didn't, there wasn't an easy way to implement it where I was and with the funding I had. But they suggested to vary and make it uncertain after a certain amount of time. They also suggested that it would be, and I think this was a really good suggestion, is to bring in like the human component of like, pair it with a psychologist or an analyst who can work with families, and that might be sort of like the additional kind of touch in addition to technology that may help, again, children realize that they may actually be feeling better now that they're using their medications a little bit more. And so I think like if I was going to do this again now, I would have heeded their advice, but on the limited funds, so like a K award, this is the best I could do.
Thank you so much. This was really interesting. I'm really struck by the intervention. It's going to the parents, but the incentive is, I guess, going to the child with the 25 cents. Did you have any like qualitative piece or any like conversations? How did it actually happen? So the parent gets a text. Was it timed like when we were like with their child? Were you able to like tailor the timings of those so that it could happen that way?
Yeah, so we were able to tailor it to the family's desire and whether they want it in the morning or night. We didn't want to bother them twice a day just because it's again, like habituation to cues and overly annoying them. So we definitely did that. There were certainly situations where parents would go to children would go to their other parent's house or their grandparent's house where, they were getting a text message. A lot of the families would forward it to the other partner or their grandparent. So we got that in from qualitative. But I think we could only put the app on one phone, and so that was a issue because a lot of the families didn't. It was like a single caregiver who was primarily responsible for the families, and so there was a decent amount of like going between different houses. Was your other question the first one?
Well, and like how did the parent communicate to the child like, oh, you got your 25 cents, or do you know anything about sort of?
Yeah, it's awkward, right? Because we're delivering the incentive to the parent or notification of the incentive to the parent and not the child themselves. These are children who most of them don't have any phones. Yeah. And so we did encourage them from the beginning to share the text messaging with the child. We don't have a good sense of like what proportion of families actually did that. So that was certainly one weakness. And I think like one other thing that I think was really important in terms of the child side of things, and we learned this from our pilot studies, is we give the children their own CLIN cards, and so there's the parent has their CLIN card for being involved in the study, and they get the compensation for study visits. and we, depending on the age, sometimes we'll give that to the child as well. But we're putting the money accrued on the child's CLIN card and not theirs. And so we make it very clear on enrollment that this is their card. It has a little Visa symbol or a MasterCard symbol. And the qualitative data is awesome on this because you get these like 5-year-old girls that say like, I got my debit card, I got my credit card, and so I think that was a key part of like making it real for them when they weren't receiving the messaging directly.
Yeah, I think it's just really interesting. I'd love to talk to you more about that. Just not necessarily parent-child, but just this other person. I do a lot of cancer work, so I was looking at kind of how can others help support the patient to do what they need to do.
Yes.
So I'm intrigued by.
Yeah, that's a good thought.
I have a question. I actually thought you were going one way with this, and I was like, oh, she's asking my question. Could you talk a little bit about the ethical implications of incentivizing children, particularly children in low-income families, for a intervention?
Yeah. We definitely, we wrote about this in the narrative review that like I think it is something that is like when do you get to the point of like coercion, right? There's another sort of aspect of this is that we had to discuss about incentives is that like, well, you're also randomizing people to like is it ethical to randomize people to do different financial conditions when a group is like clearly going to benefit, one group is clearly going to benefit more than another? So we talked about strategies to deal with that in terms of like making families all whole at the end. Like, do we actually just like sort of reimburse the AIM-3 family or the ARM-3 families with the various difference or the average of that children tended to earn in AIM-1. I think that if it was unclear whether these medications were efficacious, I think that that would be clearly an ethical violation, right? I think the more that I've learned about the concerns about transportability of research, of this research, from like, the populations in which the research was done, the efficacy research was done to the clinical world in which it's being applied. I think that it's an important like ethical conversation to have. At the end of the day, the incentives ended up being small, and so I think if you're going to start rewarding people like $1 a dose, or that begins to feel a little bit more coercive. So our IRB, like I don't know, Penn is sort of immune to this at this point because there's so many different strategies. I actually think like from a health. I do worry that there's certain families that actually, are not actually using the medicines, right? That like you don't have to like we're not testing whether it actually gets inhaled, and so in some ways like they may be choosing to pump the puff and earn their money from doing it. So I don't know if that's there's sort of still a level of choice there in whether you're actually taking the medicine that is preserved, but it's definitely something we talked about and had some conversations with my research mentors, Chris Fiedner, who's an ethicist. So I've had the benefit of that and going through some of these discussions, and I think in general it's sort of perceived to be, I don't have the ethical principles to sort of like back it up, but is perceived to be like acceptable. But I'm happy to hear pushback on that as well.
Davine Wright is a decision scientist at Harvard. She does a lot of really interesting work thinking about incentives in adolescence and the ethical implications of that. She gave a grand rounds in PEDS last year, and that's actually the only reason I thought of that question, to be honest.
Nice. Yeah, Davine, I worked with her a little bit on a collaboration in Seattle when she was in Seattle, so I should definitely reconnect with her on that. Jenny?
I have a question about individual differences in response to rewards or in internal motivation. Like in developmental behavioral PEDS, we see lots of kids clinically with different inherent motivation versus needing a lot of external motivation, or reward sensitivity or not, how much they will habituate or not. So I'm just wondering, in any of your pilot work, like it was interesting to see that 20 kids some started out really high and stayed relatively high. Others, and this was after the, after the incentives were stopped. So that's more about, maintaining the internal motivation.
Yeah.
But I'm wondering, either in the behavioral science, do you know much about individual differences, and like, do kids with ADHD have different reward sensitivity than other kids in terms of how they'll respond? Does stress and poverty change any of those aspects, and how do you think that kind of fits into your intervention?
Yeah, a lot of good questions. I don't think that there's good research on this, and I don't know how much you've looked into like the rewards sort of literature out there, because I ended up going into a lot of like developmental behavioral sort of like studies, and I mean a lot of this is applied behavioral analysis, and the sample sizes are really small. There's not a lot of, it's, a lot, like these are like N of 1, or N of like 10 studies that a lot of the sort of like science in humans or children is based on. And so it's not out there in terms of that literature. I do think that they're probably, I think what you're citing in terms of like the clinical experience of like, some children are more internally motivated. I hesitate a little bit when I said that, like, children aren't intrinsically motivated to take their medications, because I think there are probably some that are, especially if there's a parental dynamic there that like, but I think on average, like, that isn't the case. I think this is definitely an area of future work. What Jeff Colger and I were just talking about was, like in self-determination theory, the sort of like there's essentially like a spectrum of sort of motivation, where like from intrinsic motivation to like like a motivation, and what you want, you're not going to be able to, like, with some of these interventions, tap into make something like someone who loves being like playing jazz piano, right? You're not going to get into that level of intrinsic motivation with an incentive, but can you get into something that's like that aligns with that person's values or perception of themselves? He focuses on adults obviously more, and so something that aligns with the adults' values. I think similarly, like, is there something? I think this has to be more pragmatic when you get to children, and like something that actually is like valuable to them, and because their sense of self is not well developed at that point, and there's all these developmental considerations that just make this stuff in pediatrics harder.
Yeah, and if it's not like immediately reinforcing, like a stimulant medication some kids are resistant to, but when they realize over a couple of weeks their like school feels easier, they're more likely to be more internally motivated. Compared to this, you need that like 6-month window of I wasn't hospitalized, or I was able to play that.
Yeah, I don't think you need a 6-month window. As I think you don't need to get to hospitalization. I think that a lot of these kids have a lot of impairment symptoms, and I think it's like they're using their rescue medicines a lot. I think you can use that, like, they're not, because there's a social stigma about having to break out your rescue medicine, having to go to the nurse's office. And so I think that there are some both like potential like carrots and kind of like sticks that you can potentially remove, and carrots that you can put in place that may tap into that kind of spectrum of motivation where it's not all external. But I think that there's still a lot of work that needs to be done there, and I do think that like we just need to. I kind of like roll my eyes at this study a little bit now, because it's like I feel like we should have known that this was going to happen, because it's what has happened in so many financial incentive studies. It's just the thought was like, well, might it be different in children that are 5 to 12 who are like developing other habits in that age range.
Sure. I guess, how do you think about setting up incentives on a population level? So say even if there was dramatic, even after you stop the incentive and there was dramatic differences in the intervention group and they're like continuing to adhere to their medication, how do you think about, okay, yes, this incentive works, but you're not going to give 25 cents to all of Philly or all of the Northeast or all of the U.S.
Yeah.
And so I guess how do we jump to?
Yeah. So as I mentioned, I think that insurance companies are interested in, I think that's probably the mechanism. I think that they're willing, they have some funds available to partner with some of these electronic sensor companies. How the actual reward gets delivered is a good question, I think, in terms of like, I think you can figure out how to measure the behavior and establish that reward loop if it's effective. There are active programs that are going on that do incentivize like adults for certain behaviors. So I haven't gotten that far with the conversations with the Medicaid managed care companies, but I think that is the mechanism that you sort of you implement on. And it's just a cost. You know, they look at the cost of the incentive versus the cost of the, you know, if we didn't have COVID, you know, what would we have seen in terms of the effect on hospitalizations? I mean, I'm not all that rosy about that. That would have been that different because it was only a 3-month period that there was a difference in adherence. But that's your question.
Yeah. So how long does it take for a child to be notified that they've gotten an award?
Yeah. So in this study, it was weekly feedback that we were giving them. So it was the sort of notice of reward was delayed for sure.
Okay. So my other comment would be about the randomized, like the 50% chance to get a reward.
Yeah.
I think that might not work as well because
if you're not getting it, yeah.
Right, because like if someone playing slots at a casino,
Yep.
right? If they pull the lever and they have to wait a week to get the results on whether or not they won, like slots wouldn't be as popular, I would
Totally,
suggest.
yeah.
And in my own anecdotal experience, when I play like video games, right, there's a % chance of something happening.
Yeah.
But if I have
You need to find a way to sort of deliver that a little bit more, sort of, that does. I think this is. I've talked to like the head of our adolescent division, and she's like, you gotta like start focusing on adolescents, because I think adolescents would be easier because they have their own phones, and that you could deliver this. But adolescents are notoriously like more difficult in other ways, right? I think that for proof of concept of something like that, I think I'd probably study a different population because I think it's just hard in this age group. And then again, like there's still the issues of like Bluetooth, whether someone's like always syncing their Bluetooth, and whether they have Wi-Fi that is communicate. Like, can you ascertain the like outcome or whatever it is, like in a timely manner to then reward it. Like that's the challenge that we currently have. Although I think that will probably be less of a challenge over time with technology. Sarah?
Let's take it back to clinical specific question.
Mm-hmm.
So I do a lot of work around medication adherence in sickle cell disease, and hydroxyurea obviously should be taking it. But we found that while it requires really high levels of adherence to actually reduce the incidence of pain crises, very low levels of adherence can reduce acute chest syndrome.
Yep.
And so, never is anyone going to be, no one, I mean, a couple people I'm sure are 100% adherent. But when you think about daily controller meds, is there this would be a really great level or this might be okay even though it's not quite our ideal? Like what do those levels look like in those?
Yeah, it's a really good question. And by the way, I gave a similar talk at Columbia, and apparently someone has done the study in hydroxyurea, similar study in hydroxyurea, and the same result in terms of the Charlene Wong and my same slopes.
I'm sure, yeah.
And so, so what is claimed in the asthma literature is 80%. It happens to also be like a threshold that they use for run-ins for a lot of the efficacy trials too, which I think make it's a little bit like worrisome that real-world adherence is never 80%. And so if you're only keeping families in clinical trials that have adherence of 80% in the run-in period, then you're not. If the efficacy study is just, I understand we need efficacy first, but we also need to get to better effectiveness data. I agree with you that I think probably some adherence is better than none. And there's actually pretty good data on SMART for like as needed SMART. So in the GINA guidelines, the global asthma guidelines in adults, that's actually like it's codified in that actually like as needed use of this inhaler that has both reliever capacity and a maintenance anti-inflammatory effect. Like it, you know, and it just kind of, it does make sense. Like what's key about SMART is that you start taking it the moment you notice symptoms, so that you can start delivering not only the bronchodilator effect, but also the anti-inflammatory effect, and you get early. And I think that's one of the reasons why it hasn't been shown as effective, or there's less efficacy data in the 4 to 11-year-old group, because it's just hard to tell when kids are first, like, you know, starting to have any sense of limitation from their asthma. But I do think that is an important, like, I've sort of in some ways like given up on getting to 80%, because I don't think with, you know, this is like as fully loaded of an intervention as you can do potentially. With, you know, I think we could do a little more of like the tailoring to internal motivation, but it's going to be hard to sort of like lock that in and keep it with this level of intervention.
Thank you so much.
All right, thank you.